come to Mansoura for the last 30 years, I always came to the Institute of Nephrology and Urology in Mansoura. But over the last 2 or 3 years, there are two centers, two major international centers now in nephrology in Mansoura. The Mansoura New International Hospital as well as the Institute. So Dr. Osama should be congratulated for a great job he's done over the last few years. And whenever I come to Mansoura, it's nice to see all my old and new friends. So old friends starting, without mentioning age, Dr. Muhammad Sobh, Nagi Abdel Hadi, Nabil Hassan, Tariq Tantawi, and many other friends that I haven't mentioned. And also new friends and new and younger friends like Dr. Muhammad Abdul Gawad, Mona Al-Suhaimi, Muhammad Kamal, all the new generation of young nephrologists, and my good friend Hussein Shaisha, who I haven't forgotten. And I'm delighted to see in the audience Dr. Zerlul Al-Safi from Damanhur and Dr. Ghada. The Sheffield Kidney Institute and the Damanhur Kidney Unit have a sister renal center arrangement with the International Society of Nephrology. And it's my pleasure to let you know that the Damanhur Kidney Unit has been awarded the top level and the top grade at the International Society of Nephrology, which is A level for sister renal center. So congratulations to Mansoura and congratulations to Damanhur. So well done, and we'll start the talk on bone disease, and I've called it from ROD to MVD, so renal osteodystrophy. Let me switch my mobile. I've just lost my iPhone, so I'm slightly preoccupied, but otherwise no big deal. So renal osteodystrophy to MVD. What do you think MVD stands for? Because we're all familiar with MVD, mineral and bone disease, but what does the V stand for? Vascular, very much so, because it is important to put the emphasis not only on bone, but vascular. And I think a better word and a better name would have been mineral and vascular disorder or mineral and vascular disease. And we'll see throughout the lecture how the bone and the vessels interact to cause vascular calcification and renal osteodystrophy. So we'll talk about renal osteodystrophy and mineral and vascular disease. Dr. Hussein Shaisha mentioned the Global Kidney Academy, the online academy. And what we tend to do nowadays with lectures, I don't want the lecture to start here and finish here. So we started it a few days ago on the online academy with a quiz. And at the end of the lecture, I'll ask you to carry on discussing with yourselves, with us on the online academy, the content of the lecture. So we've put this quiz, and I'll just quickly run through it, because there are two winners of the quiz on the online academy to whom I'll give an award at the end of this slide. So the first question, low and high PTH and mortality. Is low or high PTH associated with increased mortality in CKD? Who's for low? Okay, who is for high? Okay, and who is for low and high? Right? So the correct answer is low and high PTH, and I'll show you some evidence. Is FGF23, fibroblast growth factor 23, calciuric? Does it increase urine calcium excretion? Yes or no? Correct, it is phosphaturic, not calciuric. What is the most effective? If you had to choose one phosphate binder, which one will be the most effective? Whether we still use it or not, it doesn't matter. Aluminium. Aluminium is probably by far one of the most effective phosphate binders. What did the DECOR study show? Okay, we'll ask Dr. Mona Sehemi.
There is no significant difference between cyclamine and calcium-containing phosphate binder regarding the effect on the PTH.
So there was no difference between cevilamine and calcium binders in relation to cardiovascular endpoints in chronic kidney disease. So it wasn't any more or less protective. And finally, perhaps we'll ask Dr. Mohammed Abdul Gawad to answer the last question. What did the EVOLVE study show? Finn Mohammed Mushaif.
The study shows that using sinacalcet doesn't decrease in the primary outcome, which was decrease in all-cause mortality and the first non-fatal cardiovascular events.
Okay, well done. So these were the 5 questions, and the 2 winners were Mohammed, if you come and get your prize, and Mona. لا منى.
مروة هي اللي
Okay, Mohammed الأول. So well done. Mona, you answered a lot of these questions.
أنا answered بس على يعني بوست الواحد بس هي مروة اللي كانت.
طب خلاص تعالي خدي وديها لمروة. Okay, well done. Okay, so we'll carry on with the lecture now. So what we'll try to do is an update on definition of mineral and bone disorder, links to vascular calcification and the role of various hormones, and update you on clinical trials in MVD. It's important, do we have a pointer of some kind, or I'll use the arrow? It's important to look at mineral and bone disorder in more than one aspect. Look at laboratory variables, and we look at calcium, phosphorus, PTH, and vitamin D. And what circulates in the serum is serum phosphorus. I don't like this expression of serum phosphate. It's not serum phosphate we're measuring. We don't measure serum calcium bicarbonate, we measure serum calcium, we measure serum phosphorus, PTH and vitamin D. We look at the bone, as Dr. Hussein just highlighted, and we also look at vascular calcification. So when you examine mineral and bone and vascular disease, it's all one big entity we're dealing with. And these are the key players: calcium, phosphorus, PTH, vitamin D, and there is one missing. No, Muhammad Kamal. FGF23. So the key players will talk about calcium, phosphorus, PTH, vitamin D, and FGF23. We start with vitamin D, just to remind you the metabolism of vitamin D: cholecalciferol, 25-hydroxy, 1,25-hydroxy. And we'll come back to that. The liver convert cholecalciferol to 25-hydroxy, and the kidney, as you know, convert 25 to 125. But we come to realize that the kidney is not the only site of one hydroxylation of 25-hydroxy vitamin D. Many sites: bone, gut, skin, monocytes, and peripheral monocytes and lymphocytes. So it's important to bear in mind that we used to think that the kidney was the only way you can convert 25 to 125. Now we realize there are plenty of sites. And we also realize that patients with chronic kidney disease are often deficient in cholecalciferol, 25-hydroxy, and 125. So a quiz: patients with chronic kidney disease have A, low cholecalciferol, B, low 25-hydroxy cholecalciferol, 125, all of the above, and it is all of the above. Then the second most important player, and the one we'll put a lot of emphasis in my talk, but even more in Mr. Halawa's talk, is PTH. So low serum calcium, thank you. Low serum calcium leads to stimulation of PTH. Stimulation of PTH will increase bone resorption to release calcium, hence renal osteodystrophy. Vitamin D increase gut calcium absorption to correct for the hypocalcemia, and we normalize serum calcium. So poor absorption of calcium triggers secondary hyperparathyroidism, which leads to renal osteodystrophy. The second player is FGF23, or the third player, fibroblast growth factor 23, which is stimulated in response to increased serum phosphorus. Serum fibroblast, or FGF23, is released by osteocytes, suppress vitamin D activation, and also suppress PTH. PTH in turn activates FGF23. So key points about FGF23, it's primarily to regulate phosphorus excretion and homeostasis, phosphaturia, reduce vitamin D activation, and decrease serum PTH levels. So our understanding of renal osteodystrophy and hyperparathyroidism has changed over the last 5 to 10 years. We used to think along these lines with serum calcium as the key player. Low serum calcium, decreased absorption of calcium, hypocalcemia would lead to decreased vitamin D released by the kidney, decreased absorption of calcium from the gut, stimulation of parathyroid hormone, and secondary hyperparathyroidism. Now we've moved from the serum calcium being the central player to possibly FGF23 being the central player. So chronic kidney disease, phosphorus accumulation, increased FGF23, suppression of vitamin D, hypocalcemia, and again hyperparathyroidism. So all roads will lead to secondary hyperparathyroidism, whether it's hypocalcemia, vitamin D deficiency, or high FGF23. Now we look at definition. The KDIGO guideline back in 2009 started to look at mineral and bone disorders in a more holistic way. So abnormalities in serum biochemical parameters, L, laboratory, B, bone, abnormality of bone turnover, mineralization, and so on, and C for calcification, to which I've added V for vascular. So we'll be thinking along the lines of LBC. Laboratory, bone, and calcification. So when we see a patient, we can look and see if they have laboratory abnormalities in isolation, L+, laboratory abnormalities plus overt and clinical bone disease. And the answer to Dr. Hussain's question whether we do a bone biopsy or not to diagnose renal osteodystrophy is that we don't do. So we don't do routine bone biopsies, and bone biopsies are only research tools at the Sheffield Kidney Institute. And then if the patient has calcification and vascular calcification, he ends up as L for abnormal laboratory, bone for abnormal bone disease, and also C for calcification and vascular calcification. So let's start with L, calcium, phosphorus, PTH, and vitamin D. It's important to appreciate that very early in chronic kidney disease, CKD stage 3, you already have increased serum. PTH are the green bars, and you have the GFR on the horizontal axis, GFR around 50 or 45, and you see a significant increase in PTH level, which goes on increasing all the way to CKD5 and end-stage renal disease. So early increase in PTH in response to hypocalcemia and in response to retention of serum phosphorus. How is PTH linked to mortality? The answer is both ways. Low serum PTH, if we look at calcium first, how is calcium related to risk of death in CKD? The higher the serum calcium in patient with CKD, beyond the recommended normal range between 8.4 and 9.5 milligram per deciliter, the higher the serum calcium, the higher the risk of death. And many studies show that for each 1 milligram per deciliter increase in serum calcium, you have almost a 25% increased risk of death from cardiovascular disease. So high calcium is high risk. Same with PTH. High serum PTH, high risk and high risk of death in patients with chronic kidney disease, but also low PTH. Low PTH tends to give you a dynamic bone disease. The bones cannot absorb and assimilate calcium anymore. Calcium goes to the vessel, cause vascular calcification, cause death. So high PTH, high calcium causes calcification. Low PTH also causes vascular calcification and increased risk of cardiovascular death. Finally, FGF23. Like PTH, the higher the serum FGF23, the higher the risk of death. So if you take different levels, low, medium, high and very high, the higher the serum FGF23, the higher the mortality rate in CKD. So all these factors, high calcium, high phosphorus, high PTH, high FGF23 are all linked to increased cardiovascular death. So give me one hormone that if it is low, you run the risk of increased risk of death. All these are high. Which one will be the opposite in relation to mineral and bone disease? Say it again. Other than PTH. Vitamin D. So low levels of vitamin D, low levels of 25-hydroxy cholecalciferol, and we'll come back to that, is associated with increased death rate in the general population, in CKD, and in end-stage renal disease. So you can see how all these hormones are interrelated and affect long-term prognosis in chronic kidney disease. So mortality in dialysis, the greatest risk of mortality, high calcium, high phosphorus, high PTH. We could add high FGF23, but also low vitamin D level. And that's why we'll see later on, we have to correct low vitamin D levels. Targets according to different recommendation, European recommendation, KDIGO recommendation, and Japanese recommendation for different laboratory variables. L, European best practice, renal best practice, KDIGO, Japanese. And the 2009 guidelines. So again, the KDIGO guideline in 2009, and you've got the link there, were more vague. So they recommend maintaining calcium within the normal range, lowering serum phosphorus towards the normal range through diet, dialysis, and we'll talk about phosphate binders. And for PTH, to maintain level between 2 and 9 times the upper limit of normal. When somebody tells you maintain normal level between 2 and 9 times the normal level, it means that they have no idea what is the ideal blood level for PTH. So now let's look at the different facets of renal osteodystrophy, the bone aspects. So we can go from low PTH levels, which are, as we said, dangerous because they favor adynamic bone disease and fractures and osteomalacia. Calcium doesn't go to the bone, so it goes to the blood vessels, and we'll see some examples. Normal, and then high and hyperparathyroidism associated with osteoitis, fibrosing cystica, and severe renal osteodystrophy. And you can have mixed lesions, and you can determine the type of lesion, usually histologically, but the level of PTH guides you whether it's more likely to be osteitis fibrosa or whether at the low level it's more likely to be adynamic bone disease. Adynamic bone disease, low bone turnover. Osteitis fibrosa, high PTH, high bone turnover. Now the most interesting and the more important is the link between bone calcification and vascular calcification. It's interesting, even in the general population and osteoporosis, whenever your bones are less calcified, the calcium goes to your vessels. So people within the general population with severe osteoporosis, age-related osteoporosis, have a higher risk of vascular calcification and mortality. And in kidney disease, you get demineralization of the bones due to hyperparathyroidism, and you get the calcium moving from the circulation, can't get into the bones, or moving from the bones and calcifying the blood vessels, or calcifying soft tissues, and then you get ectopic tissue calcifications. So it's a balance between the calcium in the serum, whether it goes to the bones or whether it goes to the blood vessels, and the tendency in chronic kidney disease and end-stage renal disease is for the calcium to go to the blood vessel and calcify them. They calcify large vessels, like this aorta there, typical tram-line calcification, and they also calcify smaller vessels like coronary arteries, hence the high risk of coronary artery disease. And the calcification pattern in chronic kidney disease is very peculiar. It's not the typical atherosclerosis with the large atherosclerotic plaques. It tends to be medial calcification. And I'll show you what happens in chronic kidney disease. The blood vessels turn into bone. So with chronic kidney disease, your arteries become bone. Your vascular wall cells become osteocytes and osteoblasts. And that's what happens. Under the influence of a lot of factors that I'll be telling you about, high serum calcium, high serum phosphorus, FGF23, the arterial smooth muscle cells turn into osteoblasts and start producing bone, calcified bone, in your own blood vessels. So patients with chronic kidney disease don't have bone everywhere. They have bone in bone, but their own vessels and arteries turn into bone. Because they have activators of calcification, phosphorus, uremic toxin, PTH, FGF23, low vitamin D. And usually you have in your circulation a lot of inhibitors of vascular calcifications, including matrix glycoprotein, phenytoin A, osteoprotegerine, etc. And these go down in chronic kidney disease. These go up in chronic kidney disease, transforming your vascular smooth muscle cells into osteoblasts, producing bone in the patient's blood vessels. And if you look at the major risk of mortality on dialysis, it is not poor adequacy, it is not anemia, it is high phosphorus and all mineral score risk linked to the highest risk of all-cause mortality and cardiovascular. Much more than anemia, much more as to whether your patient is well dialyzed and has a good or inadequate urea reduction rate. As a result, a patient on dialysis who's 25 or 35-year-old has 100-fold, 100 times higher risk of cardiovascular death than somebody in the general population. General population, low risk when you're young. On dialysis, 100-fold increase. In fact, a patient on dialysis has this, a 25-year-old patient on dialysis has the same cardiovascular risk than an 85-year-old in the general population. Same risk at 25 than an 85-year-old because their vessels are calcified. So we need to control calcium, phosphorus, PTH to prevent mineral and bone disorders, but also prevent mineral and vascular disease and cardiovascular death. So we start by trying to control hyperphosphatemia. You remember chronic kidney disease, increased retention of phosphorus, switch on FGF23 and it all goes from there. So we want to stop at the beginning and control hyperphosphatemia. Different types of phosphate binders, an old one, historical aluminium containing ones, calcium-based phosphate binders and non-calcium-based. I won't be saying much about aluminium, except to say that we've lost aluminium. We threw aluminium, as they say, we threw the baby with the bath water. Aluminium toxicities in the 60s and 70s was due to contaminated dialysis water or dialysate with high levels of aluminium. Not as much due to the 2 or 3 alucaps or alugels or aludrops that the patient was taking. And we saw a lot of aluminium toxicity. We stopped using aluminium and therefore we stopped using the best phosphate binder available. Much, much better than calcium-based binders and much, much better than sibylamine. Lanthanum has similarities as a mineral to aluminium and may be effective, if not as effective. Is dialysis, hemodialysis, sufficient to normalize your serum phosphorus level? The answer is no. Standard, thrice weekly hemodialysis will remove about 2.4 gram of phosphorus, and you'll still have about 2.4 gram of phosphorus left to clear. The phosphorus is removed from intracellular to the blood and out in the dialysate, but it's a two-pool situation, and within hours from finishing your dialysis session, your serum phosphorus is back where it was. Frequent hemodialysis or daily hemodialysis, nocturnal or otherwise, is much more effective at reducing serum phosphorus level. In fact, you can become hypophosphatemic with daily hemodialysis. So dialysis alone is not enough, and all of us will know that our hemodialysis patients are invariably hyperphosphatemic. Now, sometime I visit the renal unit, and the professor there in a developing country is very proud that his hemodialysis patients are hypophosphatemic in spite of the fact that they only dialyze 3 times a week. Why do you think they are hypophosphatemic? They're malnourished. And the death risk on dialysis is as high for low phosphorus level than it is for high phosphorus level. U-shaped curve. Low potassium, high death rate. High potassium, high death rate on dialysis. Low creatinine, high death rate. High creatinine, all the low ones are malnutrition. So don't be proud if your serum phosphate level is low. I think we can skip this slide, the long list of different phosphate binders, but just here to show you, some are aluminium-based, calcium-based, magnesium-based. Again, magnesium is an average phosphate binders, and I'll show you that there are some combinations that we use in Sheffield of calcium-magnesium binders. Sevelamer, and we'll come back to sevelamer and lanthanum carbonate. Does lowering serum phosphate level in the dialysis population impact on survival? Does the use of phosphate binders in our dialysis patients improve their survival? So show of hand, who thinks that when we lower serum phosphate in hemodialysis patients, they live longer? Nobody. Who thinks that it doesn't make any difference to their survival? Allah. Wala kida, wala kida? Okay, let's try again. Do you think that lowering serum phosphorus level improves survival? Yes or no?
Yes.
To normalization, let's say you start with a high, you normalize serum phosphorus level with your phosphate binders, does it improve survival? Yes. You would have thought it does. And there's an interesting study here that showed that patients on dialysis who take phosphate binders have improved survival. That's not a randomized study. No, they just looked at people on dialysis. Those who take phosphate binders, those who don't take phosphate binders, the one who took phosphate binders lived longer. There is a confounder. What is the confounder? The group who doesn't take phosphate binders may be malnourished. And that's why we're not giving them phosphate binders. And this may be why the group who is not on phosphate binders have a higher mortality. So you can't conclude from this one. But what they concluded, that patient treated with phosphate binders within 90 days from starting dialysis had a lower mortality hazard. So this is what you call an observational study. There are always confounders because you didn't plan it in such a way to overcome confusion. And the confusion there may be the group who's not getting phosphate binder, who's anorexic, who's malnourished, who will die much earlier. And then the next question was, what type of phosphate binder should we use? Because we worried about aluminium, so we stopped using it. Then we introduced calcium-containing phosphate binder, calcium carbonate, calcium citrate, and so on. And we started to realize that people have a lot of vascular calcification. So people made the link between calcium intake and vascular calcification, so they moved to non-calcium containing phosphate binders such as sevelamer or Renagel, whether it's sevelamer hydrochloride or sevelamer bicarbonate. And a lot of studies compared the two. And without going through all of them in details, basically the majority of studies were very small studies with a very small number of patients. And the majority was not conclusive, although one or two studies, including the Treat to Goal study, suggested in a small number of patients over 26 weeks and 52 weeks that patients on Renagel in gray had much lower coronary artery calcification and much lower thoracic aorta calcification. So Sevelamer lowers phosphorus, that's good news. Sevelamer may lower vascular calcification, that's good news. So you expect that Sevelamer will make people live longer. And the answer is it doesn't make any difference to their survival. When you do a large study, randomized, prospective, controlled study, comparing 1,000 patients on Sevelamer, comparing 1,000 patients on calcium-based phosphate binders, you look at that survival over 42 months, no difference in survival at all. So one lesson to learn in nephrology, there's a big difference between the result of observational studies and the results of randomized controlled studies. And this, you apply this to everything on dialysis. Statin, patient on statin in observational study with lower serum cholesterol live longer. You do a randomized controlled study of statin in hemodialysis patient, it doesn't make any difference to survival. One of the reasons is, I think, we still have this very naive idea that patients on dialysis all die from coronary artery disease, angina, and heart attacks. So we treat them like we treat the general population, and we think if we correct their lipids, if we correct their phosphate, if we improve their coronary artery calcification, they'll live forever. Dialysis patients are much more complicated and is so multifactorial that you cannot correct one variable and expect the patient to live longer. Plus they probably die, the majority die from sudden death. And it may not be dying from acute myocardial infarction. So Sevelamer studies, at the end of the day, Sevelamer is effective at reducing phosphorus, maybe at improving coronary artery calcification. Don't forget that Sevelamer is also a lipid-lowering agent, which would be an advantage. But there's no strong evidence that it makes any difference to the survival. And if you do a meta-analysis of all the studies, Sevelamer versus calcium-containing binders, no difference in relation to survival. So strong observational data, no strong randomized controlled trials showing superiority. So what we do in Sheffield, if the patient is hypocalcemic and hyperphosphatemic, we're happy to use the cheap, cost-effective calcium-containing phosphate binders. If the patient is hypercalcemic and hyperphosphatemic, we use the non-calcium-containing binders, which are more expensive. So it becomes a cost-benefit analysis, not as much a risk-benefit analysis. How can we control hyperparathyroidism? You saw that the two pathways, whether we start with hypocalcemia, leads to hyperpara, whether we start with hyperphosphatemia, high FGF23 also leads to hyperpara. So before we send the patient to Mr. Halawa to take the parathyroid glands out, we as nephrologists try to control hyperparathyroidism with medical therapy. Medical therapy being vitamin D treatment, calcimimetics before referring for surgery. Vitamin D, you recall, CKD patients have low vitamin D. We thought they had low 125. Now we realize they have low cholecalciferol and low 25. Low 25 is, according to observational studies, linked to higher morbidity and higher mortality. So we need to replace it. Historically, we've been giving the 1-alpha, 125 calcitriol, 1-alpha in order to overcome the lack of 1-alpha hydroxylase by the kidney, provide the active vitamin D, and increase serum calcium and suppress PTH. Then we moved on. In face of hypercalcemia, you can't give daily oral vitamin D supplements anymore because it will make hypercalcemia worse, and it will also increase your phosphate absorption and cause hyperphosphatemia. So we switched to pulse vitamin D therapy 3 times a week, orally or intravenously, and no difference at all between intravenous or oral pulse. They are equally effective. So we start with daily oral, then we move to thrice weekly oral pulse vitamin D in order to avoid hypercalcemia and suppress PTH. Then people said, well, instead of using standard alpha-calcidol or calcitriol, there are vitamin D analogues that are more effective at suppressing PTH and do not work as much on gut calcium absorption, so you don't get the hypercalcemia. This, to a large extent, is pharmaceutical spin, because practically there's no real difference between the vitamin D analogues and the standard 1-alpha. They both increase serum calcium, they both increase serum phosphorus, and they both suppress vitamin D. But the new player on the block for the last 5 or 10 years is cholecalciferol. And you'll find that majority of your patients, and the majority of people in the Middle East, surprisingly, and darker skinned people are vitamin D deficient and cholecalciferol deficient. And this is a nice study published this month in Nephrology Dialysis Transplantation, where they've given cholecalciferol and measured 25-hydroxyvitamin D to patients with CKD, correction, and low level into control. You want the level to be at least higher than 50, some will say 70 nanogram per mil. Less than 5 is deficiency, less than 15 is deficiency, less than 30 nanogram per mil is insufficient, so you really want it to be more than 30 and perhaps even more than 50 or 70. And interestingly enough, if you give cholecalciferol increase 25-hydroxy, it also lowers your parathyroid hormone. So this is the group receiving 25,000 units of cholecalciferol every 2 weeks. PTH started at 312 picogram per mil. It was down almost 50% after 1 year on cholecalciferol supplementation. So it may be just by giving the precursor, you get higher levels of 25, and even in dialysis patient, there are enough cells in the body that can convert 25 to 125 outside the scarred and failed kidney. Then we move to calcimimetics. What are calcimimetics? Normally you've got the calcium sensors on the parathyroid glands, so in the presence of hypocalcium suppress PTH release. in the presence of hypocalcemia, parathyroid hormone is released because there's no inhibition by the calcium sensor of PTH released by the parathyroid glands. The calcimimetic binds and blocks the calcium sensor so that hypocalcemia no longer causes PTH release. They're very effective PTH suppressors, whether used 30 milligram per day, 60 milligram, up to 120 milligram per day of sinacalcet, you'll get a nice sustained PTH suppression, as long as you carry on treating with sinacalcet. You stop the sinacalcet, the PTH will go up again. Surgery, once you remove the glands, you remove them once and for all. The advantage of sinacalcet, you can adjust the dose to keep your PTH within the range. You don't want hypoparathyroidism. All too often, and Mr. Halawa will tell you more about, with parathyroidectomy, you end up with hypoparathyroidism, the risk of adynamic bone disease, the risk of vascular calcifications. And calcimimetic meta-analysis on PTH, they reduce it. Calcium neutral, sometimes slightly low, neutral on phosphorus, and reduce the calcium phosphorus product. Again, so sinacalcet reduces PTH. You would have thought sinacalcet will improve cardiovascular risk and cardiovascular event. So they do a randomized controlled trial, well-powered, meaning a large sample size, one on placebo, one on sinacalcet. Primary endpoints, cardiovascular events, combined primary cardiovascular endpoint, myocardial infarction, heart failure, peripheral vascular disease, basically MACE, major adverse cardiovascular event, and the bottom line, after 5 years, no difference at all in outcome. Lower PTH, but similar survival. So sinacalcet is effective at reducing PTH, but we don't know about, and we know now it doesn't make any difference to mortality or cardiovascular event. Vitamin D and its analogues, effective at reducing PTH, but again, no data on survival, and we talked about phosphate binders. So to summarize, control of phosphorus and maintain of calcium are key therapeutics targets. We need to optimize PTH level, but we don't really know what is the range. 2 to 9 times is far too broad as the optimal PTH level. We want a low calcium phosphorus product to minimize vascular calcifications. And the treatment guidelines, KDIGO guideline, KDOKI guideline, European guidelines are primarily based on observational studies, and randomized controlled studies do not support them. Which is a problem in nephrology because we treat surrogate markers. We correct calcium, we correct phosphorus, PTH, vitamin D, maybe one day FGF23, but they don't necessarily and automatically lead to better hard endpoints. Improve mobility, decrease hospitalization, or improve survival. So I hope I've given you an overview of the interaction between bone and vessels, all the players involved, and update on the management of renal, vascular, mineral disorders. So I'll put the lecture on the online academy, and we'll try to carry on the discussion. You can ask questions. We can discuss different aspects further online for the next 4 weeks before I take it off. Thank you very much.
جدا دكتور مجيد بهذه المحاضرة الرائعة، واعتقد الجميع استفاد منها. وليا بعض سؤال كده سليم. يمكن قصة بتساءل what about number one IC as a vendor in mind, especially the sustained release formulation. But is there sufficient literature in this point, since as we know, besides being phosphate binder, it has many other beneficial effects? What's your opinion?
To be honest, we don't use niacin. We never used it as a phosphate binder, and we don't use it at all. So, do you use it yourself?
No, just, I'm asking about literature.
Yeah, I mean, there's a lot of things. There's like L-carnitine is another thing that keeps coming up in the literature in relation to anemia, in relation to phosphate, in relation to lipids, niacin as well. But I think they're all very small, underpowered, anecdotal reports, and there's no good evidence that they have any effect on phosphate binding.
Another question, our patient, of course, the economic factor is very important. Sometimes we are confronted with patients with hyperparathyroidism tertiary, which sometimes you can control the patient with Cinacalcet. But as you said, I can attain a reasonable PTH level, but when I increase the dose or I stop it, the level go up again. And the patient cannot afford for lifelong administration of this Cinacalcet. So this raises the question of parathyroidectomy. And after parathyroidectomy, the patient will suffer from adrenaline bone disease. So again, it could be also anecdotal report. What about the recombinant PTH to be used after parathyroidectomy?
So Mr. Halawa will tell us more about parathyroidectomies, risk-benefit analysis of parathyroidectomies, and cost-benefit analysis. Obviously, Cinacalcet is expensive, and it is cheaper to do a parathyroidectomy. The risk, as you said, is hypoparathyroidism. So what people may do is give recombinant human PTH, which is not cheap. Yeah, exactly. So I think the best way to do it, and I'm sure Mr. Halawa will tell you, is to do parathyroidectomy in such a way as to not to cause severe hypoparathyroidism.
The last point is regarding comparing the group of patients receiving Civinamir and other using conventional phosphate binder. And the conclusion is that no difference regarding mortality. Here I would like to say, as you do in Sheffield, usually we do our best to use a conventional phosphate binder for economic reasons. But we go to Civinamir only when we have a difficult patient to control, which is usually a patient with hyperphosphatemia and his calcium is high. So if I have a group of patients on Civinamir and follow them up looking for mortality, it would be unfair when I compare them to other good group of patients controlled by phosphate binder. If I'd like to compare, I have to compare those needing Civinamir and I give them, and other needing Civinamir and I cannot give due to economic reason, so I need them either without treatment or giving other phosphate binder. Here, I think if we do comparison like that, Civinamir will be significantly better.
Civinamir in the UK costs £2,000 per patient per year. It's a lot of money. So the first step for phosphate control is good dialysis. The second step for phosphorus control is calcium, magnesium, phosphate binders. And as Professor Sopp said, in those who are refractory and still hyperphosphatemic, use Civinamir, and you can combine it. You can use it with another binder. But aluminium hydroxide is cheap and very, very effective. And I think we need to perhaps get back and think about it. Lanthanum carbonate is similar to aluminium, and we use it in Sheffield as well, phosphorinol. I'm not sure it is as effective as aluminium lanthanum.
So I think management of hyperphosphatemia, we have to use all tools we have. I think beside diet control, I think sufficient dialysis. Sometimes I will ask the patient if he takes extra dialysis session a week, it could be less expensive than giving sevelamer.
Some of our home hemodialysis patients dialyze 4 times a week because the dialysis machine is at home and they can dialyze as they wish, and they get a much better phosphorus control than those who dialyze 3 times a week. Be careful with diet in dialysis patients, because in order to restrict phosphate, you need to restrict a lot of the dairy product and a lot of the protein, and you run the risk of ending up with malnutrition. Okay, I think I've overrun my time.
Please. There is a lot of debate about the duration of using aluminum hydroxide. Now we said it is nowadays it is already we give it to our patient. Okay, we go back to it. Okay, but the duration. A lot of people think about weeks. Some people believe it is more than that. Some people believe is that.
The protocol at the Sheffield Kidney Institute, I think we don't give more than 6 tablets a day, so that's 2 alucaps 3 times a day for no more than 3 months. 3 months. And we monitor, obviously we monitor serum aluminium level. But this is just to get over a very high serum phosphorus level, and then you bring it down, and then you carry on with your sevelamer and so on. Because you tend to have very high calcium phosphate product in some patients, and you just want to break it and bring it down again. 3 months, but it's totally arbitrary. There's no data.
What about selection criteria to shift those patients with hypercalcemia to surgical interference? وهنا to see that medical treatment failed to control this.
I think we'll get the answer from Mr. Halaw. Okay.
Regarding hepatitis C, is there any difference for mentioned in the literature regarding the difference in prevalence of vascular calcification in dialysis patient positive to HCV or negative HCV?
Right. I wish Mohammed Nasrallah was here, because he's doing a study funded by the European Renal Association precisely on that point, whether there is a higher cardiovascular risk in patients with HCV. I don't know the answer, because we in Sheffield and we in Europe have a very small percentage of our dialysis patients who are HCV positive, less than 5% in Sheffield. So I don't know, I should ask you this question. Is there a higher risk of cardiovascular complication in HCV positive dialysis patients? But all your dialysis patients are HCV positive. They come to you without, and then after 3 weeks they all become positive. Why? It's your fault.
So it's the same situation in Sheffield, but the mirror image.
Right.
We have latent patient
Who are negative.
severe.
Yeah.
So we don't have answer yet.
Okay. Yeah, just one there and one there.
I have a patient on hemodialysis with secondary hyperparathyroidism. The PTH is 1,200, serum calcium is 9, serum phosphorus is 9. And if you are allowed to choose one to use calcium mimetic or lanthanum carbonate, what will be your choice?
I would use calcium mimetic in this one. Well, the patient has very high calcium phosphate product.
Yes.
So I would use calcium mimetic.
Thank you.
Last question.
Regarding dialysis for hyperphosphatemic patients, they found that I think about the daily hemodialysis patient is superior for the conventional dialysis. In addition, also the cost here, and sevelamer is very expensive drug. So my suggestion is in case of hypercalcemia resistant, we can do dialysis against low calcium level, and then to still use the vitamin D analog.
Yeah, thank you very much. That's a point I overlooked to mention. So if you've got a dialysis patient who is hypercalcemic on vitamin D, lower the serum dialysate calcium to 1 millimole per liter ionized calcium. So use low calcium dialysate, because we give them an infusion of calcium on dialysis, and if that's not enough, then switch from daily oral vitamin D to pulse vitamin D. And if that's not enough, then move on to Calcet or calcium mimetic or Mr. Halawa. So with these words, I introduce Mr.